Good afternoon, everyone, and thank you for coming to this seminar today on delirium and medication safety. Our aim this afternoon is to share with you the key findings from our research on medication and delirium, and to engage in interprofessional dialogue on medication safety and clinical innovation. Together we will explore how research can be translated into clinical practice to improve patient safety. Some of you might find it strange that Iceland and Austria are collaborating so closely on this work. She expressed an interest in our newly established postgraduate clinical pharmacy program. And few emails later, she was here in Iceland and we had started the discussion. Since then, we have developed a great collaboration and partnership spanning a decade. And in recent years, our aim has been directed to medication safety and delirium. I think it's a nice reminder of how often reaching out can support collaboration, and it's very important for small countries like Iceland. We have planned 3 presentations for today. First, Anita will share the main findings from our research, and then we will have Tryggvi, a geriatrician, sharing his insight into the clinical challenges of caring for patients with delirium. Then we have planned Professor Barbara Sinner, anesthesiologist from the hospital in Innsbruck. Unfortunately, due to travel challenges, she will not be able to be here with us today, but has asked Anita to present her slides. Before I invite Professor Anita to come here and share with the main results from our research, I would first like to introduce some very important people who have contributed to this work and made this all possible. As everyone who has been involved in research knows, nothing would be possible without dedicated, hardworking, and smart students. I felt it was appropriate, before we start digging into the research, to acknowledge them and express our gratitude to their contribution to the work. And over the years, our team has grown. Many students from Iceland, and the Icelandic team is growing. 2 more going this winter, and soon Helga Rudd will join us as a PhD student as well. And also from Europe, and we have many students, medical students and pharmacy students. And this team certainly will grow in the coming years. And we even have a PhD student from Pakistan. Equally important, we have engaged the support of specialists whose expertise has been essential for each stage of the project. Many of them are here with us today and joining us online. So from both countries and around Europe as well. So as this project grows, so will these 2 teams, and we are deeply grateful for their contribution and collaboration. Now, let me move to the topic of today, delirium, and let me invite Professor Anita to go through some of the findings from our studies. You'll keep. Not to forget to mention the multidisciplinary delirium task force at Landspítala, which has been a great collaborator as well. Welcome, Anita.
Thank you, Freya, and thank you everybody for turning up today, both here in Iceland and online. I believe we have a bit of an audience online as well, and it's wonderful to have all these colleagues, multidisciplinary colleagues presented here and online to listen to our update of our fantastic delirium project. It's a great honour to be here today and to be working with all of you, and it's wonderful for me personally to see so many fabulous faces. So what am I going to talk to you about today? So as Freya's already introduced, we have a very large and growing project around delirium. This project came into life when I started at the University of Innsbruck 4 years ago. And some wonderful colleagues, medical colleagues and pharmacy colleagues from the hospital there came up to us and they said, oh, we're really interested in developing a pocket guide about medication risks on delirium. Would you be able to help us? And that seemed like a very sensible thing to do, because it is one of the, as one of my medical colleagues put it, one of the big challenges that are yet to be solved in patient care. And so we started on the project, and like all good projects, it started growing and growing and growing, because as we discovered the need and the seriousness of this condition, we decided to develop proper consensus guidelines for medication risk that cover both prevention, treatment, and cause of delirium. As you all know, delirium is a very sort of multifaceted condition, and medication risk is only a small part of it, but crucially it's a small unexplored part. And while there are many clinicians around the world trying to address this issue, the problem is always, what do I do in terms of medication? I have nothing to go by. There are no clinical guidance. So therefore we are trying to summarize all the information that is there and develop, together with you and all the experts around the world, consensus guidance stratified by patient groups, because every patient reacts differently to medication and it's not as easy as a one-size-fits-all approach. So to start off, I want to challenge you a little bit, or not. Brought some numbers. 1 to 88. What is that number for? What does that stand for? Well, it stands for the prevalence of diabetes, depending on the setting that you're in, and according to the literature. So the setting matters. The setting matters to determine the risk that you'll have, that you might end up with a delirium. Then we'll have 33 and 112. 33 and 112 is the number of associated factors that may precipitate a delirium. This was published in a JAMA paper last year, and they tried to collate all the factors that are available. So it's a staggering number of predisposing and precipitating factors, and medication is just one of them. 3. 3 is the number of extra hospital bed days you'll have if you have a delirium, which obviously impacts the patient's quality of life, but it also has a huge implication of economic costing. 2.6. 2.6 is the increase in mortality as a result of experience of delirium. So patients who have a delirium have on average a 2.6-fold increase or risk of premature death. And this one's easy because it's got dollar signs in front of it. And it seems to be quite a small number, 31 to 151 billion dollars. I mean, that is a lot, but actually it only applies to the US, and it only applies to dementia patients. So this is just the expenditure the US spends on dementia patients who also incur a delirium. Unfortunately, no other economic values have been published, so it's really difficult for us to kind of put a figure on it, but we can only extrapolate from there. So delirium is a very, very serious condition, And the WHO actually considers it a critical issue, which is great to, which is great to hear, because it means that maybe we will do something about that. And it's also great to see that the new ICD-11 codes do recognize delirium much more extensively than the old ICD-10 codes. But because it's such a heterogeneous condition, which has 3 subtypes, it is really, really difficult to diagnose, and therefore it is underdiagnosed, and that is also something that is very well documented. But we live in the days of AI, which is wonderful, and it'll have lots of positive impact on our healthcare processes. And there's also AI can help to predict delirium. And the tools are getting really good. There are several different ones out there, and they are up to 98% accurate. So they can predict a patient who will have a delirium with 98% accuracy, which is fantastic. And you think, hey, it's solved. But actually, for starters, a lot of them don't even take medication into account. And if they do, it's only antipsychotics, benzodiazepines, and opioids. So it's very rudimentary and very basic. And as one medical colleague of mine said, yeah, well, that's all fine and well, but what do I do if I have that information? What do I do? How do I tackle the prescribing, the deprescribing? What do I do? So in terms of medication risk, that is great. And maybe, and I'll show you in a little bit, we have a tiny AI project, and maybe it'll help us to tackle our overall aim. One last figure, 221 versus 18,500. Well, what might that be? Well, it is the number of guidelines we have identified across 412 medical and specialized organizations worldwide that focus on delirium and mention medication. They don't focus on medication, they just mention it. And I can see all the students going, uh-huh. And that is across a range of specialist medical organizations, from pediatrics to dementia, perioperative setting, oncology setting, although maybe not the oncology setting, because just about to do that next year. And that kind of summarizes what we're aiming to do. We're aiming to create guidance that is specific for clinicians and the interdisciplinary team to help them make good prescribing decisions and deprescribing decisions stratified by patient group in order to close that gap that is out there. Because one of the gaps that has, or one of the inevitabilities that it has highlighted is that we need a much, much better interdisciplinary approach to delirium. And this already happens a lot, and the literature also very, obviously propagates that. But actually, I think we probably even need to start thinking about delirium stewardship teams that, much like antimicrobial stewardship teams, why not delirium stewardship teams? Therefore, these guidances that we're hoping to develop will also be applicable to, will help the entire interdisciplinary spectrum, which is so crucial for delirium care. So, how did we go about it? When you want to develop consensus guidance, there's one methodology you should use, and that is the Accord method. So the Accord protocol states that, and I'll show it to you in a minute, that once you've done the primary admin bits and you found your research question, you need to do a systematic review of the literature out there. And then following that, you use that information to get consensus. So you do a Delphi study afterwards to get consensus. But we didn't think that was going far enough, because the literature and the quality of the literature is pretty poor. And there's not a lot of really high quality research studies, especially around the medication aspects in delirium out there, that we wanted to maximize the expertise of the clinical experts along the way, which is why we have paired our protocol with the RAND-UCLA protocol, which allows a much more in-depth discussion with clinical experts. And all of that then led to the adapted Accord protocol. And this is what it looks like. So you can see in phase 1, you have to find your team, find your research question, and then start on the systematic review. But a systematic review has to be very targeted. So we can't just do one systematic review. We have to do lots of targeted reviews in order to capture as much of the information that is out there. So we have to look at our stratified patient groups, and we have to decide what kind of information is out there, who are we interested in, what are we interested in looking at. And once we've done that, the information that we have identified, we take forward to focus group studies with you and other clinical experts of the field, people who deal with these patients on a daily basis, who make the decisions, who have all the expertise. And we ask them, okay, so this is the information in the literature. What do you think? Does that even apply? Because some of it might be outdated, some of it might be just a random report. Does that apply? And we all know that there are different prescribing strategies and treatment strategies depending on which country you're in. And obviously, if we want to develop guidelines, that needs to be part of that as well. So the focus group are a crucial element, and I hope that we'll see all of you in those focus group at one point. And then we'll take that onto the Delphi process, which ideally is going to be a process that spans all the delirium organizations across the world. So we have the European, the American, and the Australasian one. And we hope that with the help of 200 specialists, hopefully, we will be able to really identify which of the information really needs to end up in those guidelines. These are the stratified patient groups we are thinking about. And in the dark green, you can see all the systematic reviews we're trying to address. So for adult patients over the age of 18, we're thinking about original and grey literature, neurological societies, but also psychiatry organizations, and to check all the guidelines that are available for that. Obviously, for pediatrics, we want to do the same thing, especially guidelines, original and grey literature, and so on and so forth. In some of those, sometimes you see them separated out, original and guidelines. That's when there's a lot of information, or it seems that there's a lot of publications out there, and we actually divvy them up so we don't miss anything. We've done all of them, apart from 2. I'm happy to say, so we're almost through with that stage. And the 2 systematic reviews on cancer we will be doing next spring, and we already have 2 wonderful students recruited for that. But you're not here to hear about just how we did it. You're mainly here to find out what did we find. Well, suffice it to say, to date, we have looked at 22 databases. We have screened 18,500 papers. We have included 447 of them because the rest of them didn't mention medication in any form, or they didn't mention medication enough. They maybe just threw the word antipsychotics in it, and that's it. There's no information for us to pull out of it. We looked at 412 organizations and included 211 guidelines. But we are also trying to supplement the information that we get from literature with real-world studies, because that is really important. As I said before, just much like the focus groups, it makes no sense to extract all this information and not apply it to the real world. We need to know what's actually happening in practice. And so far we have looked at roughly 250,000 pharmacovigilance cases and about 55.5 patient cases. And that sounds a lot, but it's not nearly enough. And we'll discuss about that later. What did we find? Well, contrary to most guidelines which give you a handful of drug groups, so antipsychotics, opioid, benzodiazepines, sort of thing, we actually found more than 300 individual medications in more than 60 drug groups. And we're counting, because we're not finished yet with our review. We haven't even done the oncology bit yet. Does that tell us anything? Well, it tells us that this problem is much more complex than we are led to believe. In terms of the results, I will sort of skip over the adults over the age of 18, because we have been lucky enough to already have our first 2 publications out. One is the summary of the neurology guidelines, which Gudni was part of and thankfully did all the hard work for. And then we also have just recently published the original and grey literature in brain and behaviour, with which Ruth helped us with. So thank you for that. Later on this year, hopefully, we'll have the psychiatry ones published, as well as the dementia ones, which I'll go on to. But last time I was here, about 2 years ago, I was asked a question I couldn't answer. And that was it stuck with me. And I thought, I wish I would be able to answer that question. So I brought the answer with me this time around. Last time I was here, I was asked, what about opioids? What opioids should I choose in pain management? And at the time, all I could say was, there's very little information out there, and something I never seem to read about is codeine. And that hasn't changed. So all these papers later, that hasn't changed. But what has changed is that we've been able to pull together a table that gives you information within the opioid drug group for each drug, and some information that is relevant in the treatment of delirium. And most of the time it depends on the half-life of the drug, because obviously if it's washed out quicker, then the side effects might disappear quicker. And it also depends on the neurotoxicity potential. So we have compiled this table, which is in the Brain and Behaviour publication, and we have also included a column which is purely for dementia patients, because obviously pain and dementia is difficult because patients cannot articulate themselves, and we have been lucky enough to find enough information to match with the original information. So, talking about dementia, what have we found for dementia patients and DSD, so delirium superimposed on dementia? Well, and this will be, and apologies for this, you'll get tired of me saying there's not a lot of information out there. But the information that is out there spans anticholinergics, which is not a drug group, but a very difficult to find list of properties of drugs, or a list of drugs that have anticholinergic properties, antipsychotics, benzodiazepines, and antidepressants. So those are the drug groups that the literature mostly concerns itself in as a potential cause for delirium superimposed on dementia. When you look at treatment, you will also find mainly antipsychotics. And that illustrates the conundrum really quite well, because antipsychotics is something that is usually used, or very often used, for treatment. But they have the same potential to cause delirium as well. Interestingly enough, for DSD, only the medium to low quality paper talked about recommending antipsychotics for treatment options. The clinical trials, or the few that are out there, actually recommended or said that there's no evidence for their effectiveness. And that tallies with a talk I went to hear at the University of Hamburg, I think it was, at the European Delirium Association conference. There was a gentleman there who presented his clinical trial on antipsychotics use as treatment in delirium. And I was really fascinated, because I thought, I wonder what this is all about. And he talked at length about what they had done and how many patients they had recruited. And then coming to the end of his talk, he said, but then we had to stop the clinical trial because the side effects and the negative effects on the patients that were too high, and therefore the clinical trial had to be pulled. So there is no evidence for antipsychotics actually having any beneficial effect. And yet, despite saying that to the audience, he said, and yet we should use them because they work. And that kind of shows you the complexity of, or illustrates the complexity of the pharmacological treatment aspects of delirium quite well. Also, as treatment, you will find cholinesterase inhibitors for DSD patients as almost like a preventative measure to say that, you know, for hallucinations in DSD patients, that seems to, they seem to be less severe or not happen at all. But in terms of prevention per se, there really is no information other than maybe melatonin. But again, melatonin in the clinical trial that we did find, there was no statistical effect. So overall, however, it is worth to say that for DSD patients, there's even less information, there's a lot less information out there than for all the other patient groups. So the quality is, there's a real paucity and a real sort of disparity in the quality of these publications. One of the things we did manage to find is suggested therapeutic alternatives, which we have gathered together in this table behind me. And when you're looking for therapeutic alternatives, it is always usually the same sort of suggestion. So the suggestion would be newer generation of the drug, or reduced, a separate drug that does the same thing, like PPI is an H2 receptor antagonist. But that's where the disparity starts, because predictably, for H2 receptor antagonists, we found PPIs are recommended as a suitable alternative. But when we did a real-world study, we actually found that in a 10-year longitudinal database, that PPIs were significantly associated with delirium themselves. So there's a few things here that don't yet make sense to us. In the same way, we have tricyclic antidepressants due to their anticholinergic effect, or their strong anticholinergic effect, showing up in the published literature. And again, SSRIs would be the logical alternative. But although they're considered an alternative, antidepressants, we didn't actually find any significant association between delirium and antidepressants. And speaking to some of my medical colleagues, they corroborated that, saying, actually, that's not something that is on the forefront of my mind. So still a little bit of work that needs to be done, but we have compiled a list of symptoms and behavior and psychological symptoms to hopefully help distinguish, or clinicians help to distinguish the difference between dementia and delirium and what might be caused or relevant for these patients when you're treating them with antipsychotics, anxiolytics, or antidepressants. Okay, quickly moving on to POD, perioperative setting. And for the perioperative setting and the pediatric setting, we are not quite finished analysing the results yet, but for the POD setting, we have, much like the opioids table, been able to draw together the information on the difference in the grade of risk per drug in each class, which you can see over here in the orange column. And alongside that, we have any sort of special information that we thought might be really useful to clinicians. As you can see, this perioperative chart obviously covers a lot more than just anesthetics. And that obviously has a good, there's a good reason for that, because the perioperative setting spans pre, during, and post-op. And it really matters what kind of drugs you have in the run-up to your operation, and what things you're being prescribed afterwards. Funnily enough, for the alternatives again, follow the same pattern of lowest dose, new generation, short half-life. But for the perioperative setting, they seem to focus on two areas. One is anesthetics, which makes sense, and one is benzodiazepines. The information we've managed to draw out for benzodiazepines for the different treatment intents seem to also then come up with strong or suggestions for alternatives. Something you will see in the alternatives for the anesthetics is alpha-2 adrenergic agonists, so things like dexmedetomidine, and that is something that comes back and features very strongly, especially in pediatrics. Said and done, pediatrics, which Johanna helped us with. Thank you very much for that, Johanna. The literature around pediatrics seems to concentrate on emergence delirium, so the state of confusion that you have as you come out of anesthesia. It is a difficult topic, and there's not a lot of information on peds in other settings. But I know that they're working on trying to identify, there's lots of groups around the world that are trying to identify even diagnostic tools and develop diagnostic tools for that in younger children, as young as NICU children. So really tiny premature babies, normal babies, there was a lot, for the longest of time, there was a belief held that they probably don't suffer from delirium, but it's now transpiring that's probably not true. And there's some really interesting videos online that actually show what that might look like in a baby that can't talk and that sleeps most of the time, right? So that's really quite interesting to see. For us, the literature focused on emergence delirium, which we summarized, and most of it, unsurprisingly, focuses on preventative strategies. And because prevention is always better than cure, but especially in children, the preventative aspects are quite prominent in the literature, and within that, it's the alpha-2 adrenergic agonists. So dexmedetomidine, for example, that feature prominently. Very, very few studies actually looked at treatment, but what we did find in terms of treatment, again, is not quite ready for sharing. But we did find that when it comes back to prevention, things like volatile anesthetics, there seems to be a difference between whether you give sevoflurane or desflurane. So desflurane is always more preferred to sevoflurane, in the same way that intravenous induction seems to be better if you have a different anesthetic initially, and then which is then followed by inhaled sevoflurane, then having that all the way through. Ketamine and S-ketamine seem to be primarily used as an adjunct medication only. In the PEDS alternative table, you will find a lot of, well, not a lot of drugs, but a lot of dexmedetomidine. So I'll leave you to look that up yourself. We've put the references in there for you to look at. So far, that spans what we found as a quick whistle-stop tour of what we found. But you'll be delighted to hear that we've also already made a first foray into the focus groups to see what that would look like. What could a potential clinical guidance look like? And Kristen helped us with this. And we focused the pilot study on antipsychotics, mainly because there's the most literature on it. We have a lot of information. And we did this study here in Iceland at Landspítali, so thank you very much for all of you in the audience who have participated in this focus group. It was really, really important for us, and it really is paving the way for what happens next. It was a purposive sample, and what we were trying to do with this was to see if our processes are correct. Can it be done this way? B, we wanted to see what about this information that we've gathered? Is it even relevant to practice? And C, we wanted to work out, is our risk stratification table, so the layout in which we have presented this information, even useful for practice? And after the focus groups were done, Kristen very kindly took all your suggestions and put it in a new table. And this is what a new risk stratification ended up looking like. So this is one risk stratification table for adult antipsychotic use in adult patients who suffer from delirium. And you can see at the top, the white bit with lots of information is general information about antipsychotics, which might be useful. And then, and I'll quickly skip forward so you can see, and I'll come back to this slide, we have color-coded the drugs depending on their frequency of use within the drug group. So what you see at the top is haloperidol. So that's the drug that is most frequently used in the treatment. We all know that. That's not a big surprise. But in terms of layout, what you have is you have not just the drug mentioned, you also have the potential drug name, so the brand name, but you also have more information, for example, if there are multiple generations, if it's short-acting, long-acting, in other drug groups. And you have symbolic evidence of immediate things to watch out for. So you have, in this case, do not use in Parkinson patients, and be careful with liver toxicity. So it's immediate, a visual aid to see what's important. The potential guideline layout will give you information about the route of administration, the dosage, but more importantly also about mechanisms of action. Mechanisms of action as well as the type of cytochrome P450 the drug might be metabolized, so that we know how to tackle potential drug interactions or avoid them. It gives you the half-life, so you don't have to look it up, plus all the special considerations we have found that are relevant in association with this drug. And the little number at the top, little 1, want to guess what that is? It's the anticholinergic burden score. Welcome. And then the references, so you can look this up. We will start the next round of focus groups when I get back in October, and it'll be the dementia patients we'll be focusing on. And our PhD student Akil has further developed this, made a minor change to this layout at the final bracket. So where it says the reference, we're now including the reference behind each of the special considerations, so you can look it up yourself as if you want to know where does this information come from? Is it relevant to my patient? So it gives you the opportunity to look at this information specifically rather than to have to sift through all of them. And then we also provide the grade of evidence, so the Oxford level of evidence next to each of those references. So again, it's very easy to see, is this a high quality piece of evidence or not? So this is what it may look like, or maybe not, but just a little preview of what the guidelines end up looking like. So a quick recap of our real-world studies. We have been lucky enough to do 3 real-world studies to date, 2 big ones and a smaller one locally in Austria. For the real-world studies, we asked the WHO in Uppsala to give us access to the subset of the Vigibase database, which is the reporting database where 130 countries submit their interactions and side effects that they have identified in practice. And we asked them to give us all the entries for 18 symptoms associated with delirium and any medication associated with that. And then I get a phone call. And the phone call was, how would you like your database? And I said, Excel will do. All she said was, no, I don't think so. No Excel sheet can handle this. And I thought, oh my, what's coming my way? So before long, I got this wonderful email with an attachment I couldn't open. So I had to get a data scientist to open it. And it contained 37.5 million data points. needless to say, I felt a little bit out of my depth, and I thought, oh wow, I've never had access to this amount of data. But with the help of some clever data scientists, we managed to sift through that. And we managed to clean the database for any entries that were incomplete, entries that maybe had multiple entries for the same person. And after all was said and done, we were left with 207,000 patient and individual patient reports around delirium. A little bit disappointing, I won't lie, but at the same time, still 207 quality entries that we can analyze. So we used the help of very clever pharmacoepidemiologists to analyze this, and we came up with some interesting figures. Obviously, it is unsurprising that most of these were categorized as serious or ended up at hospitalization, and 7.5 of them actually ended in death or were life-threatening. But looking at the drugs, that was probably the biggest surprise for us and illustrates the difficulty with analyzing pharmacovigilance data. Because the drug that was most suspect to cause delirium in the last 20 years, no doubt, in 130 countries was the COVID vaccine. And that means at the time, and we've all lived through it, and we know that there were lots of people concerned, and there was a heightened sort of sensitization for anything that might have gone wrong. And pharmacovigilance databases are things that in some countries, normal people like the general public can actually file a report. We even had a report from a lawyer in there somewhere. So, so COVID-19 vaccine, also pimavanserin, which is used to treat hallucinations in Parkinson's patients, and carbidopa, levodopa. Those were the top three. In terms of symptoms, we came up with hallucinations were by far the highest category of symptoms that were reported, followed by delirium itself, and then encephalopathy. And I've illustrated that in this graph behind me. You can see these are the symptoms reported in relation to their frequency. Hallucinations, delirium, encephalopathy were the top three, and then you had visual hallucinations in 4, and auditory hallucinations in 6, as well as dementia in 5. And there's still this debate, and it's still unclear whether dementia is caused in some patients by delirium or is just unmasked because it was there beforehand. You can see all the other symptoms, like all the other hallucination subtypes, are, the prevalence of those is not particularly high in reporting. We also did some heat maps. So we generated heat maps that show the relationship between the drugs and the drug classes and the frequency of the symptom that has been reported. So we kind of know what to watch out for in a patient. We also did that for each, we broke it, this is the big table, but we broke it down for each drug class as well. So you have subtypes for each drug in each drug class. And of course, we looked at drug combinations. And this graph behind me looks wonderful, but in real life, it is actually interactive. So on the outside of this ball, you will find the drug classes. And the bigger the strand, the more interaction it has with another drug class. In the interactive version, you can click on each one of those, and each strand tells you this is a drug in this drug class, and it interacts with another drug. So this is a fancy graph, and we're very proud of it. But the reality is that pharmacovigilance studies, you cannot infer anything from them because they are, well, they're only as good as the reporting systems in the countries, and they're only as good as the clinicians who take the time to actually do it, which can be quite time consuming, and it is understandable that, so it's full of holes and it's full of gaps. But still gives us some interesting directions. The other real world study we did was a longitudinal study on a database you have here in Landspítali, which we were very privileged to look at, and thank you, Martin, for that. But it basically it follows, and it tracks patient data on, from admission and multiple admissions over the course of 10 years. And therefore, it gives us maybe a bit of a better reading of what is going on in those patients over time. In total, we had about 55,500 patients that are in there, and we had over 200 variables to look at. The key findings of it was that hyperpolypharmacy, so drugs if you have more than 10 drugs, was significantly correlated with a diagnosis of delirium, which means that if you look in the literature, there's a lot of talk about polypharmacy, and there's this anecdote, I will almost say it, if you're a patient in hospital and you start 3 new drugs while the patient's in hospital, he has a higher risk of delirium. But actually, if you look at where this statement comes from, it comes from a very prominent delirium researcher back in the 80s, but there is no evidence for it. It was a comment which was probably made from an observation. But it's something that has held steadfast up to now. But you won't find any entries for hyperpolypharmacy in the literature. So it is something we need to look at the differentiation there. Also, proton pump inhibitors came back as significant. So patients who developed a delirium also seem to have a disproportionately high amount of these patients had proton pump inhibitors, alongside opioids and so on and so forth. Which takes me back to my earlier point. Through PPIs as an alternative to H2 antagonists is maybe not the solution. Quite comforting for us, we found the same sort of stats for extended hospital stay, increased readmission rate, and increased mortality than are reported in the literature, which tells us that this data set and these findings are pretty robust. We didn't find, however, a statistical significant association between tricyclic antidepressants and delirium, for example, which is curious because tricyclic antidepressants are known to have a high anticholinergic burden. So, again, something we need to think about. And the same with type 1 diabetes. The literature seems to suggest there's a strong link there for all the obvious reasons. But again, in our data set at least, we didn't see that. And just because we weren't busy enough in the last 2 years, we did a couple of additional studies on the periphery. Things that we followed up from what we found so far and our main mission to develop these guidelines. So we had the opportunity to do an interview study with geriatric patients at a hospital in Austria. Not geriatric patients, geriatricians and intensive care medics who are treating delirium patients. We also identified some possible leads for a causal relationship between delirium and the microbiome and delirium and pharmacogenomics as possible, in relation to pharmacological treatment. And if you stop and think about that for a second, that actually makes a lot of sense. And there's growing evidence that the microbiome is involved in all sorts of diseases. And there's a lot of literature on microbiome and depression, for example. So we wanted to know, is there evidence on microbiome and delirium? And especially medication use in delirium. And lastly, because AI happened, and we're all very excited. We obviously also had a little AI project, because when you do lots of systematic reviews, you have very stringent criteria of inclusion and exclusion, which means you exclude a lot. And while I always thought, well, I'm happy with what we're doing, I know the quality is absolutely perfect, I still didn't. There was always this niggle in the back of my head. I don't know what I don't know. And there's a lot of literature out there that we might be missing. And I thought that I might be able to help us with that. So we developed our own AI called DelStar, and we trained it on all our systematic review papers. to see if it would come up with the same conclusions we have drawn. And then we gave it access to only the scientific databases, so PubMed, for example, so that it doesn't pilfer from the internet to kind of reduce the quality of the information we receive. And I'll tell you about how that went in a second. So in the qualitative interview study, we use the theoretic domains framework, which is an sort of underpinning theoretical framework that allows us to determine behavior and behavior change in relation to, in this case, caring for and prescribing for delirium patients. And I would imagine that a lot of these, you know, most of you will, this will ring true with most of you, because what we found is that medication in relation to delirium is a topic in relation to treatment. But it's not necessarily a topic in relation to prevention. And it's also, what we found is that a lot of medics said that they're not really aware that there are differences within the drug class. And that's understandable, because a lot of the guidelines that we have seen, they kind of give you a list of drug classes to avoid. Not drugs within a class, but drug classes. So that kind of wasn't a particular surprise. And I guess this doctor was very honest, and he said, well, actually, it is very often the approach is very much trial and error, especially when it comes to medication. And again, that's totally understandable, and I think that's where we are in terms of our understanding of this and how medication is involved in this. And again, this issue about identifying it, especially diagnosing hypoactive delirium, came up as being really, really difficult. For the microbiome study, we found very few papers that dealt with microbiome and delirium. But nevertheless, they were really interesting because they had 11 distinct bacteria that were changed, and they were either significantly more prevalent or they had disappeared altogether. So there was a change in these 11 bacteria, and overall there was a reduction in the alpha and beta diversity in delirium patients. They also showed differences in or changes in short-chain fatty acids, systemic inflammation markers, and neurotransmitter modulation. All of this has been known before, but it was interesting to see how this was linked to the microbiome. And crucially for us, no information was available on medication-related changes to the gut microbiome in delirium patients, and we even decided to scrap the microbiome part and just look at the delirium part and just look at medication effect on the microbiome, because it makes a lot of sense to us that of course there will be changes. You know, think of antibiotics, for example. You know, and every other drug will have the same effect or an effect. So it makes a lot of sense that there should be an effect of medication on the microbiome, but there is no data out there. And there's certainly no information on how that would affect delirium patients, or whether that helps precipitate or prevent one. So another gap identified, and it's a lead for us to start maybe exploring. The other lead we found was the pharmacogenomics aspect, because both microbiome and pharmacogenomics information will help us have a bit more personalized medication approach to patients in the future. The pharmacogenomics project we haven't started yet, but we do have a student who will start in October, and she will scour the literature first to see what's out there. And finally, the AI tool, our wonderful Delstar 1.0. It was fab to work with it. I have to say, at one point we decided so we challenged it in all sorts of different ways, and at one point we gave it fake drug names. Now, I have to say, for all the pharmacists in here, that is not a good thing to do, because over the course of a month, when you constantly are faced with fake names that sound almost the same as the real names, and the real names, all of a sudden your brain starts thinking, oh, that might actually, oh yeah, I've heard of this before. And you think, no. It doesn't exist. But this particular tool did well. We did lots of different evaluations, but we're not quite there yet. So we have developed DELSTAR 2, which looks at tree of thought models. And again, we'll be evaluating it this coming autumn. The idea for this is that it'll act eventually as like a postdoc assistant, like a research assistant. So someone you can ask when you're trying to find information about treating a patient, or you want to research a particular patient case, could there be a link to medication? What is the evidence of this particular combination of medication in relation to delirium? And you know that you can trust it because it's purely based on, it's very transparent. It's not like the normal black boxes that we are used to with AI. You know exactly where the information comes from, and you know that it is hopefully an additional tool for the interdisciplinary team out there. Whew. So, what's upcoming next? Well, obviously we want to complete our focus groups. And we want to then subsequently finish the international Delphi study. We also want to do a lot more real-world data to improve the guidance we can give and the relevancy of that guidance to practice. We also want to follow up those leads on microbiome and pharmacogenomics. And obviously that requires continuous grant applications. The problem is, though, that at least for industry, there is no interest in delirium, and therefore there are no big grant bodies that would, give out lots of money for that. But there are grant bodies that you can apply to under the topic of patient safety. So we aim to do that, and we have had some success already. This September, we've been able to get medical university ethics for all our focus group, which is a big thing for us because it means we don't need to go back for every single patient group we want to look at. And in October, which is not on here, we'll start the focus group for the dementia patient group. So watch out for an email. At some point, you'll get an invitation. In November, we have two more wonderful Icelandic students joining us, Ásta and Rafnhildur. And they will do focus group studies for the pediatric aspect and the analgesic aspect in adults. And we'll have a student looking at the pharmacogenomics systematic review. Following that, we have had some success. We have our first European co-funded networking grant in Aurora. And it says here it starts November, which is a lie. It starts after this meeting. So it is, hang on, it is, so that's quite, so watch this space. Then we have Helga Root starting in January, which is wonderful, and she's going to tackle the perioperative aspects. And we will hopefully have another PhD student starting earlier next year, as well as 2 master students who will be doing the oncology systematic review, and hopefully 2 more PhD students and a postdoc to help Freya and me to tie it all together, because as you can see, it's grown very quickly. And there's a lot of things to think of, and this postdoc will hopefully help us in managing this entire project. I'm really looking forward to the discussions with you after this, because that's the whole point of this, to get your input and see what else we can do, get your critical thoughts on this. And I'm looking forward to a great discussion, which is maybe we won't take questions now, but we'll have the discussions afterwards. So thank you so much for this wonderful team. I had a quick look at the slide that I presented 2 years ago. The team was about 1/3 of the size, and it'll keep growing, and I'm so delighted and privileged to work with these people. So thank you very, very much. And I will be handing over to my wonderful colleague, Tryggvi Þórir Egilsson.
Klárurnar kannski. Okay. Og klárurnar eru hér. Gjör svo vel.
Hello. My name is Tryggvi Egilsson. I'm an internist and a geriatrician, and I'm very honored to be given the task of giving this short talk. I work at the Landspítali, and delirium has been a kind of an interest of mine for the last 2 decades. And I've been mostly working in the acute geriatric ward and doing consultations on the internal medicine and surgery wards, and amongst other things, and also teaching the medical students about delirium and the young doctors, and taking part in a working group here. So this is a short talk. Mainly I was asked to talk about my clinical experience and the challenges that we face in our hospital. So this is kind of a little bit local view maybe on this issue. Well, our hospital is a 600 plus bed hospital, general and specialized hospital services. And the values are safety and professionalism, amongst others. So it can be a challenge to uphold these values, especially when you have a high bed occupancy rate of 100% on average, which is much higher than is recommended, and up to 150% in the ED. So patients who need admission stay on average more than 24 hours in the ED, at least in the last few months. I looked at numbers in July. So it's a very big challenge to use preventive measures. I'll come to that, which are so important to try to prevent delirium forming in admitted patients. We have this 122-bed acute geriatric ward. We don't have any geri psych unit. We do have a unit for demented patients, but that's in another hospital, and it's not used for delirious patients. So patients are frequently admitted to other wards, basically the medicine wards, and I want to present you kind of one typical case, a challenging case. 85-year-old male with a history of mild forgetfulness, anxiety, hypertension, osteoarthritis, and visual impairment. He lives alone, he's independent, except he needs some assistance from his daughter with his meds. He presents to the ED with a cough, fever, and fatigue. He's on tramadol, amlodipine, sertraline, and diazepam. He has fever, increased respiratory rate. He's awake and oriented when he arrives. There are crackles in his lungs. He has dry mucous membranes. He has some elevation in his CRP, WBCs, and creatinine. And there is an infiltrate in his lung. So he is admitted to a ward. He was one of the lucky ones not to have to stay in the ER for too long. So he was admitted to the hospital, given ceftriaxone, paracetamol, and he had some sleeping problems, so he was given zopiclone, and there were really no other changes in his medications. Urinary catheter was placed, and vital signs ordered. He was mostly in bed and assisted to the toilet. He was on regular diet. But the next morning, he became disoriented, had difficulty finishing sentences, and had some hallucinations. So the question is this delirium or is it something else? And could we have prevented it? The challenge is that we missed opportunities basically to save patients. We could prevent so many more than we do, because we know now, and we've been actually knowing for the last 2 decades, that we can prevent probably a third or more of delirium cases. Obviously not those who have delirium when they arrive to the hospital, but the other half we could do so much better job with. And basic things like stimulating the mind, focusing on hydration, nutrition, constipation, urinary bladder, to rule out distended bladder, and focusing on infection, mobilizing the patient from the start, on pain and medication overview, seeing and hearing. People with hearing aids need to have them because otherwise there's increased risk of delirium, and focusing on sleep hygiene, not with medications but with other things. It's a challenge knowing that we could do so much better, but so we are losing too many patients to develop delirium with with increased risk of bad outcome. So such falls and length of stay is increased risk of mortality, a nursing home, etc. And back to the case, this is so common that we failed to do these obvious things. Should we have given him fluids IV when he came? He had dry mucous membranes. Should he have been encouraged to drink more fluids and monitor fluid intake? It's easy to do, but it can be very complicated in a busy ED setting, obviously. And did we rule out urinary retention with a bladder scan? Did he have his glasses and hearing aids? Was he mobilized? We don't know. Was PT involved? Did he really need the sleeping pill? Were his medications evaluated? Did he have a pharmacy evaluation? And why did he have the urinary catheter? Sometimes we are not even sure why a catheter is placed, and it increases the risk of delirium. So it's a challenge, but we can always do better. It's a challenge also. It's such a common problem. Up to 1/3 of 70-year-olds in patients either have delirium on admission or develop it after admission. Very common after surgery in the ED. And just taking our little hospital, 600 plus beds, we have around 7,000 admissions for 70-year-old to somatic wards every year. And according to estimated, keeping in mind numbers from other researchers, probably the prevalence is around 1,000 per year and the incidence is 800. So it's very common. And we now have a clinical pathway since 2024, influenced by the NICE guidelines. But we need to do much better job in screening for delirium. But basically, according to these guidelines, we are focusing on the risk factors, elderly, history of cognitive impairment, hip fracture, recent and severe illness. And if there's any suspicion of confusion or delirium, we suggest doing the 4AT. It is a tool to assess for delirium. And if there is no suspicion, we suggest doing daily screen with DOS. This basically is a checklist that's used by nurses and nurses' aides based on observations during regular care. And it actually has very good sensitivity and specificity. But we have not been doing this systematically, and it's being done in some wards, but not others. There is also a challenge in diagnosis. We suggest using the 4AT assessment, which is very quick to do, 2 minutes, very good evidence. More than 6,000 patients have been examined in 20 or 30, at least many studies, and very good sensitivity and specificity, and been tested in a wide range of settings in the hospital. But it's in relatively few cases we are documenting this kind of structural assessment of delirium, and we miss it or we don't document it in our hospital. Less than 15 to 20% of the cases. I've been looking at the numbers over the last 10-15 years, and this is even less than is reported in some other studies. So I'm not going to talk about all these, 200 plus different predisposing and precipitating factors, but pathophysiology, many etiological factors. So that's a challenge to find out what's the cause in each case. Usually it's a mixture of 2, 3, 4 precipitating and predisposing factors. And it can be a challenge to diagnose it from all the differential diagnoses, the most common being dementia, or this is supposed to be delirium superimposed on dementia, and Lewy body dementia is also a differential diagnosis, depression, psychosis. So all these differential diagnoses can be a challenge, but it's very, very common for maybe young doctors to think that elderly person who comes into the hospital has some psych symptoms like depression and anxiety, to think it, they should call the psychiatrist from the beginning, but not realizing that delirium is much more likely explanation for these symptoms in a elderly, acutely ill patient. And it's also a challenge how much to investigate. Sometimes we don't really have to investigate a lot. Sometimes just basic blood tests, but sometimes we have to do very extensive workup with imaging studies and so on. And we often miss doing the basic things like good history and physical, and ask about alcohol use. Over-the-counter medications are often forgotten. Ruling out urine retention and constipation, subtle trauma. So these are the things we miss, and I think are a challenge in our hospital. But usually we're doing a good job of taking all the regular blood tests and so on. There is no good medical treatment, but there is still high expectation for us to do a lot if patients become delirious in the middle of the night. There's a pressure to often medicate the patient, even though he's not necessarily restless or agitated. And staff often overlook other causes. Is it just pain, or is it constipation, or distended urinary bladder, so on? And there is tendency to give too high doses and oversedate with antipsychotics, benzos, or clomethazole. Often there is no EKG available, even though a patient ends up on considerable doses of antipsychotics, so we don't know the QT interval and so on. And sometimes we forget Parkinsonism is a contraindication. No good medications, but still I think there are exceptions. Sometimes we, like Anita said, we know the antipsychotics don't help in general, but still sometimes they do in some cases that are distressed with hallucinations, paranoid. You sometimes see the difference. People feel a little bit better, so we still use them. But the thing is, you have to use them really, select the right patients, low dose, short term, maybe just 1 or 2 days, very low doses. But in general, medications are not the main thing. It's all the other non-pharmacological treatment. And we know this from many different guidelines from all over the world. It's not my role to talk about these guidelines, but these just came out 2 days ago from the American Psychiatric Associations, and they agree with the NICE guidelines. If they use medications at all, it's going to be, they suggest Haldol in a low dose. So no news, really nothing changed there. And there's also a challenge in communication. In a crowded hospital, we have to uphold laws regarding patient privacy. It's difficult in a room with 9 patients and just curtains between the beds. And also regarding communication with the relatives, it's also very stressful for the relatives. Many times they've never seen their parent, this confused before, and you really have to find time to explain to them, and that can be a challenge also, and involve them in the care to support the patient. There's also a challenge of before the patient is discharged, after the hospital stay, lowering the doses. Sometimes we find out the day of discharge that he's still on the haloperidol or some other medication he was given. So we need also to make sure they have appropriate support at home, family physician follow-up and memory clinic. That's how we do it in Iceland. If the family doctor thinks it's appropriate, sometimes obviously there's a dementia also underlying. And there's a continuing challenge to educate and improve knowledge about delirium in our hospital, which has a high turnover of staff. I've been involved in this since, we did these clinical guidelines in 2015, and now we have a clinical pathway since last year. And but we have been stepping forward continuously in the last 10-15 years. So I think we are doing a much better job, but it's a continuing challenge to, keep it in the discussion and in the culture. There are so many, maybe doctors my age or younger, that often think delirium is something that's expected in elderly patients. You really don't need to look for the causes, or it's a cultural thing, how we misdiagnose it, underdiagnose it, and so on. So we need to educate everyone in the healthcare staff, really. It's not just the MDs and nurses, but also other healthcare staff. So that's what we've been doing. But thank you very much.
Anita will take over now, and
Okay.
then we'll have a panel discussion afterwards.
Perfect, thank you. Right, hello again. As Freya explained, our Professor Sinner, who's the chair of the Department of Anesthesia and Intensive Care Medicine at the Medical University in Innsbruck, unfortunately has encountered some travel issues and is unable to present this today, but she has very kindly sent me her slides, and I will do my best to represent her work for you. She, at this stage, she declares no conflicts of interest, and we'll dive right into the area of delirium that she's most concerned with, which is obviously the perioperative delirium, so post-operative delirium, or POD for short. There are 4 general risk factors, or main areas of risk factors that span or that can occur during perioperative or post-operative delirium, which is procedural related factors, patient factors, obviously peri and post-operative factors in turn. And these are the procedures that carry the highest risk of having a post-operative delirium. Cardiac surgeries are by far the riskiest ones, followed by sort of large joint surgery trauma, which is something that, and joint replacement, which is something that is also quite prevalent in the literature, especially things like hip and knee replacements, and any sort of surgery that where you have a lot of blood loss and a very extended length of surgery are also carry the highest risks. The factors that the individual risk factors within these different groups are multifold. So for a patient, for example, for the patient characteristics, this is the thing that we know most about, because the patient is at the center of everything we do. And occasionally you would have the mindfulness of maybe stopping a major surgery such as cardiovascular surgery, because the risk to the patient is just too high. And unless it is severe dementia, this does not apply for increased cognitive risk to patients, i.e. anyone with an increased risk of postoperative delirium, that would never be a reason to stop a surgery or not have a major surgery. Because it's just not in the mindset, and that goes back to maybe what you just said, that it's just not in the part of the surgeon's mindset. The perioperative factors are probably modifiable risk factors. So you have anxiety, which is normal and common, which you can treat, but stay away from benzodiazepines because they're not helpful. But things like thirst and sleep disturbance, there's all sorts of things that you can do something about that prior to surgery. But then for the post-operative factors, Professor Sin is sort of observing that there is delirium often is a precursor to some of the more dangerous consequences of surgery, things like sepsis or organ failure. And it's almost like it's the same phenotype, but it's a very different sort of pathomechanism that precedes that. And again, we know very little about that. So action is definitely needed across the entire spectrum. And Professor Sinner's group has a lot of different projects that are trying to tackle these various aspects. One of them being the inclusion of neurologic patients, because a lot of the neurology patients are excluded from pod studies because they would skew the results. However, they have a specific focus on neurology patients, and using their electronic database, they can screen for these patients, and they can include up to 1,000 patients per group to see if there's any association between the neurologic disease and delirium, and try and help answer these questions. But there's also a focus in her work on prehabilitation prior to surgeries. Now, prehabilitation means pre-operative rehabilitation, and it basically means obviously optimizing the patient's state of health or mobility in order to ensure the surgery has as fewer complications as possible. And that very often it has three guiding principles. One of it is obviously the exercise and the mobility that goes along with that, and in some cases the nutrition, and the third pillar is psychobehavioral aspects of this. In the clinic in Innsbruck, they have a prehabilitation program when patients undergo hip or knee surgery, they actively undergo this prehabilitation exercises. And Professor Sinner's group has started a project where they looked at major visceral surgical procedures, because most of those they have access to 2 weeks prior. Cardiac patients, they usually see a day before. Hip and knee replacements orthopedic patients are usually already in the system, and they get some form of prehab. But visceral and surgical procedures, they have access to 2 weeks prior. And the current program contains physical training and optimization of nutritional improvement, as well as correcting the odd deficiency like iron deficiency, for example. But the neurocognitive prehabilitation is currently only has a minor role in this setup. And the literature on this is also more or less very, very poor, and it hasn't really been studied. So what they have decided to do is come up with the pre-operative cognitive initiative training to prevent post-operative related neurocognitive dysfunction, or precognition for short, in collaboration with Professor De Francesco at the Memory Clinic. And the idea is that for all bristle surgery patients, they get, in addition to the physical and the nutritional support, they get it's like a test book with cognitive tests 2 weeks in advance. And for every day there is a task to complete, be it a Sudoku, be it a memory exercise, and they follow these patients for 4 weeks post-operatively to see if there's any relation to the occurrence of post-operative delirium or post-operative cognitive decline. And they check for adherence, just to make sure that, you know, that variable has been removed. But actually, what is important to point out is that these test books are in paper format, because especially elderly patients, they found that the adherence on a sort of computer format wasn't particularly useful. So they have 185 patients in this randomized study, and they do follow them up for 4 weeks after. The study is still ongoing, so unfortunately we haven't been given results along with that. Another project that the group is doing is based on this idea that there are a lot of aberrant stress responses during an operation. And there's this known disbalance, neurotransmitter disbalance, especially acetylcholine, as well as sort of age-related changes in the decline of the parasympathetic system that lead to increased levels of neuroinflammation and obviously a reduced resilience in the human brain to buffer those crucial changes. So the study itself looks at this aberrant stress response by measuring the heart rate variability. And they do this by using this wonderful machine, this analgesia nociceptor index machine, which was at some point developed to determine just this cholinergic disbalance and measure heart rate variability, because it was linked to a measure of pain during the operation. Unfortunately, back in the day, that didn't work. So that showed no benefit. So Professor Zinner's group has repurposed this machine in order to look at the heart rate variability and try and map that as an indicator to this parasympathetic and sympathetic stress response. The patients do undergo neurocognitive examination prior to the surgery, and it's usually hip or knee arthroplasties under general anesthesia that are included, and then they are tested for levels of delirium and post-operative cognitive decline following procedure for up to 4 weeks later. Excluded are patients that are with an emergency surgery, which makes a lot of sense, atrial fibrillation, Parkinson's disease, multiple system atrophy, pure autonomic failure, history of autonomic dysfunction, stroke, cerebral neoplasia, and major depression. For the post-operative studies, so this is the machine, For the post-operative studies, these are still under construction, and it is based on this idea that, or this observation that delirium very often preempts or comes first prior to sepsis or multiple organ failure. And they would like to explore the differences and the different origins, because the phenotype, the pathomechanism is different despite the phenotype being almost the same. So that follows on some of the literature that we have discovered, and maybe even the database we were lucky enough to analyse from Iceland, where it showed that there were some patients who had up to 17, I think 17 was the largest number, Freya, correct me if I'm wrong, but there were patients who had up to 17 diagnosed episodes of delirium. And some had, and there's literature reports of people having very prolonged period of disease or delirium that doesn't resolve properly. And Professor Sinner's group wants to see what happens during this sort of resolution of delirium, because that too isn't particularly well explored. So they want to have a good look at the different biomarkers, EEG, and clinical presentations linked to these patient cases. And this is the group in Innsbruck under Professor Sinner's care. And she says tak thera. Is that right?
Thank you, Anita, for doing this well for Professor Sinner. Now we have had an overview of our studies and key findings. We have had the clinical challenges from Tryggvi in Landspítali settings, and now from Professor Sinner in Austria. Now we would really much like to engage in a dialogue, and I would like to invite Tryggvi and Elva Þöll, who is a main nurse in Landspítala, to come join us here for the discussion. Elva leads the steering committee for delirium in Landspítali and has extensive experience and knowledge about challenges in delirium. So, first of all, we haven't offered any opportunity for questions, so maybe I open the floor by offering if anyone has a question or comment. Maybe if I then start, one of the challenges that we find in for example, pragmatic trials in real world data set is the underdiagnosing and underdocumentation. We have had that discussion with, for example, Professor Martin, which is a challenge when you're looking into the prevalence incidence of these cases. Anyone has a suggestion or how we can tackle that?
We should maybe point out that the people who are watching online, you can join in the discussion. So there is a box for you to put in.
Is someone observing that?
And yes, somebody is observing that.
So Helga Ruth is going to observe that and let us know if there are any questions or comments. Please bring comments. It's a lot that we have thrown at you today, both a lot of challenges. Please, Martin.
So I think for Anita and for Tryggvi. So I think for Anita, regarding sort of the methodology, because there's so much association, and you see that people frequently report medications that we use to treat or think we're treating delirium. They are then reported as risk factors, for lack of better word. Are there methodological ways to take apart like the chicken and egg? And same for dementia and delirium. We'll see delirium being prevalent in patients with pre-existing dementia and dementia being diagnosed as delirium, and this all goes back and forth. It makes it so hard. And I'm also thinking about the case reports that you showed, that where people are reporting medications that are being used in patients with Parkinson's with hallucinations as risk factors for hallucinations. And this is just so prevalent also when you speak with patients that people have sort of cause and effect.
Absolutely, it is
confused.
really difficult. Oops, sorry, thank you. It is really difficult to determine the cause, the exact cause, especially in something that is so multifactorial. And I don't think, if I'm absolutely honest, we'll never get to a point where we can 100% say this is caused by this or by that. It is multifactorial after all. But it is important that the knowledge base that we have, which is already really, really useful. There's the help, I guess, framework that has been developed in order to look at all the other non-pharmacological aspects in the patient care. I think it's important that we try and at least provide advice and some suggestion on how the pharmacological part plays in that bigger picture, because it might just be the thing that triggers it. Because the thing that I've always wondered is there has to be something that it's almost that kind of, it's the last drop in the pond, something that causes the patient to have delirium, which is so different in every single patient. And maybe, at least for my part, I know that it makes a lot of sense that medication, the right or the wrong one in this particular patient, can be that final drop that causes the patient to actually display symptoms. So I don't think we'll ever get to the point where we can be 100% sure that this is what causes it, but we can certainly try to at least get all the information and all the pieces of the puzzle so that every patient can be assessed individually as well as possible. I don't know if that answers your questions, Martin, but yes, it is difficult looking at things like pharmacovigilance databases. I think COVID-19 and pimavanserin even, those are things that shouldn't be there, because is it causal or is it a correlation? Which one is it? And a lot of these drugs are being used to treat, like pimavanserin, for example, is used to treat hallucinations, and yet it turns up. And there are many more examples that I didn't show you today where it's a similar sort of thought process. But I do think that it is a vital gap that we need to close, even though we'll never be able to have certainty that that's what's causing it.
I also know it's regarding RED, and this is a problem everywhere. I mean the people who are waiting the longest are very frequently the highest risk for delirium, because they don't have a track, like their course through the hospital is not as clear as somebody who has a STEMI, right? Because they will have a 2-day hospitalization, including a procedure, versus the people who have been waiting for 140 hours are frequently the elderly and frail, super high risk for delirium, also on a lot of medications that they're probably not receiving in ED, and their hospital course is so unpredictable. I do feel like, is there a way to do this better? I always feel it's the people who benefit the least from staying in ED that are staying there.
Well, it's a continuous challenge. We have this 22-bed acute geriatric unit in Landspítala Fossvogur, and every single day there are maybe a handful of patients, or at least 1 or 2 or 3 in the ED that really are appropriate for that unit. But sometimes we only can take 1 or 2, and we try to prioritize those with delirium. Take them to this acute geriatric ward, but obviously we can't take all of them, and we just have too few beds. And that's a whole other discussion. The healthcare system, why the patient flow is slower than it should be, and so on. But the bottom line is we don't have enough beds for these people, and there's also a challenge if they get really, few patients can get kind of aggressive and very, very agitated, and our unit is not even the best unit for those patients. So then there's a psych unit that can take them, intensive care psychiatric unit that's in the very rare cases for very, very agitated patients. But in general, it's just too few spots. So these people end up in, on other wards where there are mainly pulmonary patients or ID patients or, can end up anywhere basically. So it's a continuous challenge to keep on educating the staff about how to deal with or support these patients the best we can. And back to the issue of medications, it's also I feel it's medications are sometimes the tipping point, like Anita said. You may have a patient elderly, frail, with pneumonia, but he's also on 7 medications, and 3 or 4 of them could be contributing to the delirium. So there's a challenge to, try to lower the doses a little bit, switch to other medications that are more or better, but like all your research is aiming at is trying to find all these other options which are not always clear if we have in each class of drug. So yeah, it's a interesting challenge.
Yeah, I would like to add to the question, can we do something more or better for those patients who are waiting in the ER? The answer is yes, but with it's a little bit complex, and we need additional resources. We have a unit. The ED unit is staffed with people that are trained to work in the acute setting. They are trained to save lives and do the first assessment. And that's what they are doing very well, and that's what is the priority of their work. When they have extra 10, 20, 30, 40, 50 patients waiting, while they are also always getting new patients, that is where the problem starts. If we could add people into that unit that are focusing on moving the patient, working on the preventive measures, because we have a full hospital already. So that is one thing. Can we add assistants that into the unit to feed them, to move them, to hydrate them, and to focus on all these preventive measures? That would be helpful, I think. Also, is there a way we can prevent them from coming into the ER by other kind of service, urgent care service or assessment unit, which I recently heard is coming, hospital at home, etc., educating the people who work in the home care settings so that the barrier or the threshold is higher for people to come to the ER. So these are just a few things from the top of my mind, trying to answer the question of Martin.
You have a question?
Hello. Thank you very much for all this information and very interesting talk. And I think you all have said one point that's very important, because well, my interest comes from the ED. I work in the ED as nursing specialist, and we actually, my main part there is to get older people safe to go home. But we also have this problem with, the rising number of patients there and rising number of delirium also. And I think we could do one thing, which is very simple to do right now. That is, with every patient who's supposed to be admitted, there would be a plan to prevent delirium. Because we don't have that. We don't diagnose delirium. We don't do enough of assessment of it. And that comes with all the staff, not only the doctors, the nurses, and all. But we have, rising awareness of it. We have that already. And I think there's a huge challenge there to have a plan. Because there is sometimes a plan that we will do it when the patient will be admitted to the unit. And that might be 3 or 4 days later. And we also have a statistic from the Hagdeild that we have longer stay in the hospital if you stay longer in the ED. So we have a lot of challenge there. And we are always trying. So I think that we can add this puzzle at once.
Any other questions or comments?
Can I maybe
Yep.
answer, or just not answer, but comment? I think that's an excellent point, and I think this idea about delirium stewardship teams is really important, because I think it, much like antimicrobial stewardship teams, and you have a wonderful delirium team already, it brings it into the forefront of people's mind. So it's all of a sudden, if you call something everybody knows that antimicrobial stewardship teams are really important to prevent antibiotics from stopping to work and doing the bit that everybody gets the right antibiotic at the right time that is appropriate. I think in the same way, if you have a delirium team that has is interprofessional, has very skilled colleagues in it, calling it a stewardship team raises the profile of delirium automatically. So wherever you look in the literature, I think the treatment for delirium is interdisciplinary and multifactorial and mainly non-pharmacologic, which as it should be. But I think, like you say, if we can do more to have that as a standard practice in our hospitals across your country, my country, then I can't speak for the other countries, but I think it would automatically raise the awareness and automatically do something for people to promote even their own training and their continuing professional development. Because that is one question I certainly have for the audience is, what kind of training would you need or would you like to have around delirium and around maybe medication and delirium? Because that is something that you're all dealing with every single day, or come in contact with.
That's an excellent question. I'm excited for the answer.
Actually, I have one thing to add to it. I think we might have this. I have one thing to add to it. I think if we have this, maybe if the patient is supposed to be admitted, he will be stay longer and everything like that. You have to do this a little bit screening of the risk. You have to do some. It's so simple and everyone can do it, So, but someone has to be responsible for the planning of the patient, for the plan. What are we going to do next, and how are we going to do this? I think I don't think we have to add extra people, because I think everyone knows. Mm-hmm. We just have to know how we work it out. You see. Thank you.
I just, coming back to your question about the ER, how much we could do there from the beginning. I mean, it's no rocket science, but if the patient would be admitted to the acute geriatric ward, it would be a routine to check the bladder to rule out bladder distension, do a residual, to look at measure fluid intake every 8 hours or something like that, mobilize the patient at least 3 times a day, and screen for delirium. We could do this as a kind of a standing order in the ED if the patient is, if there has been a decision to admit the patient, but it's just the practical issues like, 9 people in a small room, there's maybe 1 meter between the beds. It's very difficult to expect that the ED can do all these things. So I guess we kind of sometimes fall into the trap of just thinking, well, maybe we can't really do it well there, maybe we should wait, but maybe we shouldn't do that. Maybe we should try to raise the bar higher and formalize some kind of standing orders for people who are, if there has been a decision made about admission, there could be a package of orders to look into all these things. Physical therapy is now much more, involved in the ED than 10 years ago, so that's great, and we could improve things much more. But the best thing would be to kind of increase the flow of patients so that they wouldn't have to end up in the ED for 24 hours. So that's kind of the basic problem.
Aðalsteinn?
Yes, I'm a geriatrician at Landspítali and have interest in polypharmacy among other things, and I should say also, perhaps today we are talking about hyperpolypharmacy as well. It's a new term. But I think, just to put a focus here on, I'm looking at the agenda here, and it's drug safety, and I think there have been so many touchdowns here, and it's an ongoing journey, but it's also an ongoing journey for us to learn and be humble as well, because this is also happening in a relatively short period of time. Delirium is not new under the sun and was present before medications surfaced, even. Yeah. One thing I just want to throw out few hints here. I mentioned polypharmacy, hyperpolypharmacy. We could also add there is a lack of understanding in clinical trials how the drugs are developed, because rarely you have dementia. These are usually exclusions, dementia. Even having a remote history of delirium might exclude you. So that's a tricky thing. And then furthermore, we are up against the wall, because we are talking about perhaps hyperpolypharmacy, associations between dementia, predisposing to delirium and being vulnerable to drug effects. And then we have drug interactions and drug disease interactions. But what is of crucial importance, I think, is how we are interacting about drugs. Because talking about delirium, we are not so quick in blaming a drug, but we are very quick on thanking a drug. We are thankful if the drug helps, because it exposes how desperate I think the situation is. So I think we have to be very careful there. But I want to just add that the drug dose is often a forgotten thing, because it's so easy to grab from the databases we have. We have the drug. It's a yes or no. Yes. But what is the dose? And furthermore, what is the dose for that individuals when you look at the pharmacokinetics and even more so the dynamic aspect? And you mentioned, I think it was you, Dr. Weidmann, you mentioned how we know little about the gut, what's in it, and how it's controlled with all the synapses there. So we have that, and we have the pharmacogenomics. So it is, I'm not desperate, but I'm saying this is, we just have to recognize this when we take these steps. But I wanted to ask you, if I start with, if I ask the three of you kind of to take the ball onward, but I want to maybe ask Tryggvi also about your experience. You're the most experienced clinicians among or geriatricians as well in terms of the delirium. What do you think of the back mirror, where people have been many times in the hospital? It sort of gets forgotten. Should we learn more from previous admissions? Should this be somewhat of a journey, whether we do it through the medical record or some other ways?
It would be a good start to mention it in the discharge record in the beginning. So that's the problem. People sometimes have had delirium 2 or 3 times in the last 10 years, but it's not documented. So because once you have had a delirium once, you're always at increased risk of developing delirium again. But I'm not sure how to answer that question. In the back mirror, there are so many things we could do better, regarding screening and diagnosing delirium and making sure people are not left on medications that increase the risk of delirium. There is a big tendency to always add medications, but many doctors are afraid of weaning patients off medications. If there was another doctor that started the medications 10 years earlier or something like that. So, polypharmacy is a big part in this whole picture. But it's a wide question. I'm not sure how to answer it unless you can focus it a little bit.
May I add?
Yes, please. Just go.
Yeah, you were talking about documenting previous delirium from the last visit. I would like to start with documenting it within the visit, because we are moving patients around, and sometimes they have had delirium in one unit or in one even bed, and they are moved to another unit or something, and we never highlight this person had delirium episode last week and it's under control now, be careful. So this should be a red flag. If a patient already had the delirium within this hospital stay, that should be flagged, and so we don't let him wait for a pain medication, we don't let him wait for toilet, etc. So that, I think we should start there.
How would you plug it? Put it in the snow cone, or that's one question. And then I'm thinking about our skills to deal with these patients. Because I was just thinking about, can we practice and train skills better?
Of course.
Because it's usually difficult cases, and you have to have some skill, have experience to deal with it and know where to focus. And maybe, we could do something about that.
Yeah, I think using the snowflake is a good start. But I don't have the answer to it. But and also, of course, we can do more training, and I think the younger generations of both nurses and physicians and nurses aides are better prepared than the older versions.
Yes. One addition. It's also easy to look up if it's documented in our computer system. If you do the DOS or 4AT and it's documented on the screen, the information is there. It's easy to get the information, but it's more difficult if it's only in the text, in the notes. So that's some kind of a start, at least.
I think coming at this from a sort of researcher's point of view, I think one of the things that we need is more pragmatic trials. So not really high-powered, excellent clinical trials that are really difficult to do, but pragmatic trials that maybe pitch one strategy against another, or they combine non-pharmacological approaches with a pharmacological approach to see how that helps, because I think that is something that is woefully lacking. We're talking, when you're looking at the literature, we have a lot of case studies and we have a handful of trials. So these are the two extreme ends. What we need more experience with patients, documented experience from patients that can be used for research purposes, so we can then share that and pass on that knowledge. I think that's the only chance we'll have to find suitable strategies, because I think at the moment everybody's poking in the dark a little bit, and that's obviously the thing that we're trying to tackle. And in order to do that, we need these pragmatic trials. And the question is, how do we go about that? Not everybody has an electronic database of patients. Some are still, paper-based. So how do we go about these pragmatic trials? It doesn't always have to be the gold standard. It can maybe we have to start small and just work from there and start gathering that evidence that shows which strategies, be it pharmacological, non-pharmacological, or combination, do actually work best in our settings.
I think we need to tie this together. We're coming to the end. It's already past 3 in Iceland, 5 in Austria, and so I think we need to close this session. But I'm grateful for the participation. I'm grateful for our speakers, and we invite you to contact us if you want to collaborate or if you have any comments. I think it's an ongoing challenge. A lot has been done in Austria and here in Landspítali, and we will keep at it together. But I just want to thank you for coming today, taking the time to be with us.